Good evening, and welcome to this evening's episode of the Komen Breast Cancer Education Series, an evening with Komen Scholar Dr. George Reis-Filho. My name is Dr. Serena Wong, and I'm a medical oncologist at Memorial Sloan Kettering Cancer Center. Today, I have the pleasure of speaking with Dr. Reis-Filho about some of the exciting research he's conducting in the area of estrogen receptor positive or ER-positive breast cancer. Dr. Reis-Filho holds a joint medical degree from the University of Porto in Portugal and the Federal University of Paraná in Brazil. After completing his residency and fellowship in pathology, he went on to receive his PhD in breast cancer molecular pathology at the Institute of Cancer Research and the Royal Marsden Hospital in London. He's been the recipient of several awards, including the 2007 C.L. Oakley Lectureship by the Pathological Society of Great Britain and Ireland, the British Association for Cancer Research 2007 Translational Research Award, the 2010 Ramsey Cotran Young Investigator Award by the United States and Canadian Academy of Pathology, and the 2010 Future Leaders Prize by Cancer Research UK. In 2012, Dr. Reis-Filho joined Memorial Sloan Kettering, where he's currently the Director of Experimental Pathology. His current research interests are in the development of biomarkers and in the establishment of a predictive classification for breast cancers based on their patterns of DNA repair defects and genetic instability, and in defining the causes of intratumor genetic heterogeneity in cancers. Thank you, George, for speaking with us today.
Thank you so much, Dr. Wong. It's such an immense pleasure to be here with you and to have the opportunity of discussing our research observations, our research program, and how these can impact on the lives of patients with breast cancer, in particular, estrogen receptor positive breast cancer patients.
Yes, I know you have a large amount of research interest, but in the interest of time, the focus of our talk today is, as you said, going to be on estrogen receptor positive or ER-positive breast cancer. And I'd like to begin by giving our audience a sense of the scope of what we're talking about. So first, how common is ER-positive breast cancer?
ER-positive breast cancer, or hormone-dependent breast cancer, comprises the vast majority of breast cancers. As a matter of fact, if we get a population of patients with breast cancer, greater than 75 to 80% of the patients will express the estrogen receptor in the tumor cells. And we know that these tumors have a specific natural history, clinical behavior, and they respond to varying degrees to endocrine therapy, which has come to become the mainstay of treatment for patients with this form of breast cancer. Germane to our understanding of the disease as a whole is the recognition that breast cancer is not a single disease. It's a collection of multiple different diseases that happen to affect the breast. So estrogen receptor positive and estrogen receptor negative breast cancers are fundamentally different. And that's why it's so important for us to recognize the existence of these subtypes, embrace that diversity that we are confronted with in the clinic, and then study each one of them in great detail to identify the drivers, what actually results in the behavior that they have clinically, their responses to the therapeutic armamentarium that we have at our disposal today, and also to understand how can we personalize the treatment to individual patients.
Thank you. So we estimate that in the US, over 280,000 women will be diagnosed each year with invasive breast cancer. And over 150,000 women are currently living with metastatic breast cancer in the US. So if we say that 70% of these women have ER-positive breast cancer, using the definition of strict, ER positivity, we're talking about a very large number of women who are affected by this. And
Yes.
as you mentioned, the mainstay of treatment for these ER-positive breast cancers has been endocrine therapy or anti-estrogen therapy, of which we have a number that we developed over the years, including the selective estrogen receptor modulators such as tamoxifen, the selective ER degraders such as fulvestrant, and aromatase inhibitors which suppress estrogen production. But unfortunately, as we know, resistance to endocrine therapy remains a significant challenge for us, and a proportion of patients with early stage breast cancer relapse despite being on therapy, and those with metastatic cancer experience progression on their cancer while on treatment. Do we know overall what percentage of ER-positive breast cancers demonstrate resistance?
So that's such a wonderful question, and it's such an important one. Let's go bit by bit here. So first, you're absolutely correct in your assertion that there's a large proportion of women with metastatic disease that are ER positive. And I would contend something even further, that the biggest challenge that we have in pathology and oncology at present when it comes to breast cancer is in the management of these patients with ER positive metastatic disease, because now they comprise the majority of patients with metastatic disease in the context of breast cancer. And here, the behavior is important to describe. There are some patients that upon receiving endocrine therapy will experience very long periods of remission, and after 10, 15, and sometimes 20 years, develop a relapse. There are others that will develop a relapse within the first 5 years. And there are some that progress even during therapy. And it's a mixture. It varies according to the patient characteristics, the tumor characteristics, and the therapeutic agents we're using. We are very fortunate, however, now that we have a large number of treatments available, as you have described. And I would add to that the CDK4/6 inhibitors as well, which to some extent are endocrine therapy agents as well, because they target cyclin D1, which is one of the genes activated by estrogen receptor. And the combination of these agents has basically helped us extend the lives of patients with metastatic ER-positive breast cancer by many, many years. However, studies from our group and many others, when I say our group here at Memorial Sloan Kettering, that you're part of as well, our group has demonstrated that there is a multitude of mechanisms of resistance that are operative in patients with metastatic ER-positive breast cancer. And again, we have demonstrated that these vary according to the biology of the tumor, but also the therapeutic agent. So studying the intersection between the two is absolutely crucial for us to be able to tailor the therapy to the patient that's in front of us in the clinic, or better, in this case, in front of you in the clinic. I'm a pathologist by training, so the microscope is my clinic, yeah? So in that context, we have come to understand through the work, similar work by Sarasha Dalapati, one of our colleagues here at Memorial, that when patients receive aromatase inhibitors, one of the mainstays of treatment for patients with metastatic ER-positive breast cancer, the most common mechanism of resistance is in the form of a mutation affecting the ligand binding domain of the estrogen receptor. These mutations make the need for the ligand of estrogen receptor, namely estrogen, obsolete, and the receptor keeps activated in the absence of estrogen. But there are many additional mechanisms of resistance, and these vary, as I said, according to the tumor type, the subtype of ER-positive disease, and the drug used in the clinic.
Thank you for that. Yes, as you mentioned, there are multiple mechanisms, some being intrinsic and some being acquired. And the example that you gave with the ESR1 mutation is one such acquired mechanism. What about intrinsic mechanisms? Can you tell us a little bit about what we know with respect to certain features of a cancer itself that might signal to us that we might be seeing some de novo resistance in a particular case?
Absolutely. That's, again, such an important point for us to contextualize how breast cancers respond to endocrine therapy or anti-estrogen therapy. We understand now that ER-positive breast cancers comprise a spectrum of lesions, going from the ones that have very active estrogen signaling and low proliferation at one end, which some refer to as luminal A cancers, to the other extreme end of the spectrum, where the estrogen signaling is rather incomplete. It's not exactly what we would expect based on the textbooks, and they have a high proliferation. And we have everything possible in between, okay? So we know now that some of these tumors that are the luminal B, one of the extreme ends of the spectrum, the true luminal B tumors, they don't respond that well to endocrine therapy. And in that context, a combination with chemotherapy may be desirable, and there are tests that assess that in the adjuvant setting. But we understand that within the metastatic setting, this type of associations are also present. There are no tests for that at present, but we understand that this plays a role. The second point is that some alterations present in the tumor seem to be enriched in those that become metastatic. And for instance, chromosomal instability is one feature. 53 mutations in the tumor suppressor gene called TP53, which was the gene of the year in the 90s, and also known as the guardian of the genome. 53 alterations actually predispose to genetic instability and are also associated with more aggressive behavior and to some extent some level of intrinsic resistance to endocrine therapy. We understand that, for instance, for CDK4/6 inhibitors, there are some alterations that can be present before treatment that address the cell cycle that's targeted by CDK4/6 inhibitors that may be present in the tumor and cause them to become resistant. Having said all that, we do not have clinically validated assays that tell us upfront on their own whether a tumor is de facto resistant to endocrine therapy. We know that the ones that do not have estrogen receptor at all, those will be resistant because they don't have the target, yes? However, we don't have a clinical assay in the ER-positive tumors to say for sure they will not respond to hormone treatment.
And can you talk a little bit about the various signaling pathways that might get upregulated over time and can thereby act as a mechanism of acquired resistance?
Yes, and here we're talking about a large number. We know that many receptor tyrosine kinase pathways can be activated upon, let's say, hormone treatment. And these actually then signal to the cells to keep dividing, surviving and dividing. We know that the machinery that controls the transcription within the cell, transcription factors, can also be altered and result in acquired resistance to endocrine therapy. And another recent observation, but a rather important one, that is the realm of genes that control how the chromosomes, how the chromatin is organized in the nucleus. If they are altered, they can also cause endocrine resistance. And it's really fascinating here because the way our DNA is organized in the nucleus plays a pivotal role in the differentiation of a cell. And if this is altered, it can actually convert an estrogen receptor positive cell into an estrogen receptor negative cell, making the cell resistant to endocrine therapy as well. But we have done extensive genetic analyses of primary tumors and then the respective metastatic sample, or even between metastatic samples after a therapeutic intervention in the middle. And we can figure the mechanism of resistance based on genetics alone in around 40 to 50% of the cases. But I'm afraid to say that even using the most state-of-the-art genetic approaches, and I'm a person really into genetics, that's what I do for a living, I'm afraid to say that we cannot identify or pinpoint what is really making that tumor resistant. So we need to go above and beyond genetics alone. And we are beginning to derive additional clues of potential mechanisms here in terms of dormancy, in particular for the late relapses, convergent types, meaning many different alterations that convert to the same signaling point that, for instance, promote cell cycle dysfunction that cannot be addressed by CDK4/6 inhibitors. So there's a plethora of different mechanisms that we have yet to characterize. And that's why the support from Susan G. Komen in this area is so crucial, because this is not going to be resolved by a single laboratory in one research institute. This will require a collaborative endeavor and embracing all the different ideas so that we can come up with a synthesis of something that will be really meaningful for the patients.
Absolutely. And as much as we've gleaned from our research now, it seems like we're really just barely skimming the surface of what lies underneath. So I want to move on to something else related to your research. Amongst your many interests in research is studying the impact of DNA repair defects on resistance to endocrine therapy in breast cancer. And I do want to delve deeper into your observations and the exciting work that your lab has been doing. But before we do that, can you first explain what we mean when we talk about DNA damage? And what are the ways that cells normally go about repairing such damage?
Absolutely. And this is one of the, I would call, Cinderellas of cancer research, because it's been, completely rediscovered here. Okay, we have known for decades that DNA repair defects would constitute one of the hallmarks of cancer. Since the seminal perspective by Doug Hanahan and Bob Weinberg many years ago, outlining the hallmarks of cancer, we know that. But until recently, we could not target it well. So we studied it from the perspective of biology, but now there are ways that we can leverage DNA repair defects. So what do I mean by DNA repair defects? First, we need to understand why we need DNA repair. One of the key principles in evolution is that our DNA repair is not perfect. And there are many different pathways to repair different types of DNA errors that happen during the life of a cell. For instance, when a cell is dividing, it can accumulate mutations, and it can accumulate even structural rearrangements of the chromosome. And during this process, different types of DNA repair mechanisms need to be operative to correct them without leaving another error behind. One of the most severe types of error in the DNA is when the double helix is broken. Imagine a DNA double strand break. And that can be really toxic for cells because it can bring together two different chromosomes. It can create really major structural damage to the genome of a cell. So the cells have a DNA repair machinery called DNA damage response and homologous recombination DNA repair that address this type of errors. Okay, and for instance, there are other mechanisms to repair point mutations where only one of the letters of the DNA is altered, or only when a little bit of DNA is lost. There are a multitude of pathways, each one to address each one of these different types of DNA repair defects. So, and how do DNA repair defects end up happening in cells? As I mentioned, even cell division can result in the accumulation of errors. We have cytotoxic insults coming from environmental exposures. For instance, if we go under the sunlight, we can accumulate Cs to TT alterations, the dinucleotide alteration so characteristic of UV light, or if one smokes, they accumulate a very specific type of set of alterations. Or if a cancer cell has a mutation affecting one of these genes that controls one of the pathways of DNA repair, the cells accumulate those errors. And you may ask me, so where does that happen? In breast cancer, we have two or a few great examples. Mutations in BRCA1, BRCA2, PALB2, and a few other DNA repair genes like ATM or CHEK2. Those mutations result in inactivation of the HR, homologous recombination, or DDR pathways. And then in the life of that cell that has had the inactivation of that gene, errors are being accumulated gradually over time. And that's why the individuals with germline mutations affecting these genes have an increased risk of breast cancer development.
Thank you. So you mentioned that this type of defect in DNA repair can put people at risk for developing breast cancer. What about the impact of these types of defects on the response to endocrine therapy? Do we know anything about that?
That's the very topic of my proposal.
How did I guess?
My research grant with Susan G. Komen. So we know that there is an interaction between homologous recombination DNA repair and estrogen signaling. The interactions and crosstalks there are far from being well characterized. We know from a few studies that, for instance, loss of BRCA1, because BRCA1 is involved in DNA repair, but other functions in the cells as well, may lead to a conversion from estrogen receptor positive to negative. We know that the behavior of estrogen receptor positive breast cancers in BRCA2 germline mutation carriers, their behavior appears to be different, and that not uncommonly they can develop that type of quicker, let's say, relapse upon endocrine therapy. Not all of them, of course. We're talking about associations, but we see overall, if we look at a large number, we can see that some of them actually develop more quickly a relapse. So what we have set out to do is to understand how losses of these DNA repair genes impact on estrogen receptor signaling, and the differences that they cause. How can these be leveraged for us to target DNA repair defects in those cancers? And why do I say that? Because we can borrow from the example of PARP inhibitors in BRCA1 or BRCA2 cancers. So in BRCA1 or BRCA2 cancers, the cancer cells do not have competent homologous recombination. And we know that those cells are very sensitive to DNA double-strand breaks. If you increase the number of DNA double-strand breaks, they have to resort to error-prone mechanisms to repair them, and the cells cannot tolerate that amount of errors that are accumulated then. So when we give PARP inhibitors to a patient, only the cancer cells have complete loss of BRCA1 or BRCA2. The normal cells have still one intact copy of BRCA1 or BRCA2, so the normal cells are fine. So when we give PARP inhibitors in the cancer cells, they will inhibit base excision repair, which is a different DNA repair mechanism, or they will bind to the replication forks, and by one or both of these mechanisms, they cause a lot of DNA double-strand breaks that in the normal cells are corrected with homologous recombination, but cannot be corrected by homologous recombination in the cancer cells. And then they die. So on the basis of this principle, which is called synthetic lethality, we target something that the tumor cells cannot do. Yes, using this principle, loss of the two results in cell death. So by using this principle, we can then ask the question of whether specific types of DNA repair errors, other than BRCA1 or BRCA2, could they be targeted together with endocrine therapy so that we can individualize the treatment for patients on the basis of the DNA repair defects that the tumors harbor. So that's what we're seeking to investigate with our proposal.
Fascinating work. And with the goal of your research ultimately being to create more effective therapies, can you tell us a little bit more about what an effective treatment might look like and what it could mean for our patients?
Well, there are many potential opportunities here. For instance, we know that cancers with, for instance, ATM mutations. ATM is, again, another tumor suppressor gene whose loss or whose germline mutations confer moderate risk of breast cancer development. But there is a substantial proportion of estrogen receptor positive tumors that harbor ATM loss of function. Those tumors are not very sensitive to PARP inhibitors, but they seem to be sensitive to other DNA repair targeting agents. But on their own, for instance, I'll give you an example of ATR inhibitors. That is a new class of agents. On their own, ATR inhibitors are not that effective. We are talking about a few percentage points in the metastatic setting. So our idea here is, can we combine this with endocrine therapy in a meaningful way? Or can we use other agents targeting DNA repair pathways in the context of these specific losses that we observe in a substantial subset of patients with metastatic estrogen receptor positive breast cancer? So that's one of the potential ways. And then we have to answer the question, if we do combine them, are we going to combine them at the same time concurrently, or are we going to do them in a sequential manner? So how and what would be the optimal schedule for the treatment of these with these combinatorial agents? And for us to be able to get there, we'll need to understand the crosstalks between DNA repair and estrogen receptor signaling and cell cycle and all the different aspects that are required for us to bring them together. It's daunting at times because there are so many variables involved, but we are really blessed here at Memorial, and we are also blessed by the support that we have from Susan G. Komen, because then we can borrow from the expertise available locally and in the scientific community to address this multitude of parameters that we need to address to be able to get to that point.
One question I frequently get from my patients is, why are we not using immunotherapy in the treatment of ER-positive breast cancer?
That's a phenomenal question. Okay, regrettably, so far, monotherapy or just combination with conventional chemotherapy and immunotherapy in the context of ER-positive disease, the results have not been that impressive. And it's a question of not having optimal biomarkers here, ways of identifying those few patients that would respond from this type of treatment. And perhaps because the optimal combination with immunotherapy would not be conventional chemotherapy. And again, here, and that's what makes me smile, because I feel really excited. One of our ideas is to leverage the DNA repair defect, a DNA repair targeting agent, and add an immunotherapy backbone to it. Because a study published by Dr. Nadim Rias's group in collaboration with ours in Nature Cancer last year, we demonstrated that BRCA2 cancers display an exquisite sensitivity to immune checkpoint blockade. This was a retrospective study backed up by several, let's say, animal models. So we are confident that the observations are correct. We do not know how frequent this happens in the clinic, but we understand we have a signal here to support the contention that specific types of DNA repair defects may predispose to increased sensitivity to immune checkpoint blockade. We have not got to the point, however, of having an assay that will tell us, oh, this patient has this DNA repair defect and actually benefits from immunotherapy. And that's one of the aims of my proposal as well. So the development of these biomarkers. So I owe you a drink, because that is a phenomenal question. Thank you so much.
I'll take you up on that. While we're on the topic of developing novel treatments, I think we'd be remiss not to touch on a very hot area right now, which is the role of antibody drug conjugates. And specifically, in light of the recent data regarding the role of trastuzumab deruxtecan in the treatment of ER-positive, HER2-low breast cancer. Can you talk a little bit about this new category of breast cancer and how this is going to impact our definition of what we've been calling ER-positive breast cancer and the way we treat it?
I gave you a short sigh because you have just touched upon perhaps one of the most profound observations that we've made in the context of breast cancer in the last decade. There is the development of these drugs, these antibody drug conjugates that can target the so-called HER2-low tumors. Because I think the impact on pathology and oncology will be immense. And why do I say that? Because from a taxonomy or classification perspective, clinically, currently we classify breast cancers into ER-positive or ER-negative, and then HER2-positive. And when we say HER2-positive here, is HER2 amplified or HER2 3+, or not HER2 3+ or amplified, correct? So that's what we've been doing for many decades. And why is that? Because there were treatments for these different subtypes. So we never paid attention to the tumors that were not HER2 0. They were HER2 1+ or 2+, and did not have HER2 amplification. And why? Because they were considered to be ER-positive, HER2-negative clinically, and they would receive the same treatments as all of the other ER-positive breast cancers that did not have HER2 amplification. But now with the development of TDXT, those patients have come to become important. So we have to go back to our classification strategies, to the assays that we use to identify HER2-low cancers and identify these cancers regularly. And why? Because in particular, in the context of metastatic ER-positive tumors, there will be a large contingent of the population that actually is HER2-low. And they will be perfect candidates to be treated with this type of antibody drug conjugates that show activity in that particular setting, ER-positive, HER2 1+ or 2+. And the benefit that we have observed in the trials so far is incredible. So I think this is so incredibly exciting. And from the perspective of a DNA repair person here, and of course I have to bring it back to DNA repair, I find it really exciting because these antibody drug conjugates are oftentimes an antibody with a linker, and then the chemotherapy agent there is nothing but a DNA repair targeting agent. In the context of TDXT, is a topoisomerase 1 inhibitor. So this brings back to the whole discussion that we had before. How do we leverage DNA repair targeting in the context of metastatic disease? And I think that these recent developments are paradigm shifting for the whole population of patients with estrogen receptor positive disease that's metastatic. And I think it's a new hope. I'm not saying that's going to be the panacea and will be the solution for all of our problems, but it adds something really substantial and something really meaningful to help those patients.
So I would love to continue picking your brain on this because I think it's such a hot topic and so much to discuss. But I did want to move on to something that I have a question about. Given that cancers are dynamic and constantly change and evolve over time, ideally, as a treating oncologist, I would want to know what's happening in an individual person's cancer cells in real time so that I can adjust my treatment appropriately. Can you talk a little bit more about the role of doing serial biopsies, and in that context, perhaps the role of liquid biopsies and how we may be able to use that information that we glean from each of these?
Dr. Wong, you already alluded to this point when you asked me a previous question that is about acquired resistance. So understanding how the disease is evolving, what are the alterations that the cancer cells acquire upon a given treatment, and how they become resistant, is essential for us to be able to define the trajectory of a cancer in a given patient. In the past, we used to do this all empirically, but now we do have the tools to monitor patients in a way that's personalized to them as well. It's not only personalization of the treatment, but personalization of the monitoring. I would submit here that the introduction of these plasma DNA assays in the monitoring of patients with metastatic disease will change the whole treatment paradigm. We have already accrued several lines of evidence to demonstrate that we can identify a large subset of patients that will relapse within 1 year or 18 months by increases in the amount of tumor DNA in plasma that we can detect with specific assays. Now, we do not know yet exactly how to intervene then, and studies are still required. But I truly believe that this information can help us plan and design the therapeutic strategies for a given patient. Now, I have to say that it's really challenging to navigate the different types of assays for liquid biopsies currently available. We have assays that are devoted to the detection of minimal residual disease. We have assays that are liquid biopsies, basically trying to survey all of the different alterations that may be causative of resistance in a tumor or in a patient, not in a tumor, in a patient. And we have assays that are simply for the detection of tumor DNA in plasma. They vary in sensitivity, they vary in specificity as well. And at the moment, I think we still need more studies to define what is the optimal type of assay in a given clinical setting. But the beauty is that these studies are being carried out. And so I would say that in 2 to 5 years, this type of monitoring will become, let's say, one of the major ways we monitor patients in the clinic.
Thank you. Well, you are certainly a wealth of information, and I wish we had more time so I could pick your brain. But I would like to thank Dr. Reis-Filho for speaking with us today. And thank you for sharing your insights and the results of your groundbreaking work that you and your lab are performing. And as we were speaking, I couldn't help but think about the original paper from the 1800s by the Scottish surgeon Beatson, who discovered that by removing the ovaries of a young woman with progressive metastatic cancer, he was able to induce a profound and sustained remission. Of course, it wasn't until decades later that we start to understand the role of ovarian ablation and blocking estrogen as a method for treating breast cancer. But here we are over a century later with a much more sophisticated understanding of the different types of breast cancers, multiple drugs that block the estrogen pathway, and the ability to identify specific signaling pathways within an individual person's cancer cells. It's truly remarkable. Do you have any closing remarks or thoughts that you'd like to make?
I have one point to make here, that it's never been as exciting to be a translational researcher as it is today. The opportunities that we have, given the technological developments of the last 20 years, the incredible support we're getting from Susan G. Komen and other funding agencies, as well as the engagement of the patients and patient advocates. Now, actually, we can translate the groundbreaking basic scientific discoveries into benefit for cancer patients in the space of years, not decades. So it's incredibly rewarding to see, for instance, Alan Ashworth and I made the discovery of reversion mutations in BRCA2 as a mechanism of resistance to PARP inhibitors. And we have already seen the translation of these observations to guide the treatment of patients with BRCA1 and BRCA2 cancers. It's in the space of less than a decade. It's incredible to see the opportunities that we have to improve patients' lives through the work that we do in the laboratory. And to have the privilege of coming to work to do that is incredible. I could not feel happier and more blessed.
I agree wholeheartedly, and I'm so thankful that there are brilliant minds like you at the other end in the laboratory making new discoveries every day that I can then translate into treatments for my patients. Well, I'd like to end by thanking our audience for tuning in, and of course, thanks to the Susan G. Komen Foundation for their ongoing support. We've certainly made great strides in our fight against breast cancer, but we still have a lot more work to do. And we hope that through the continued collaboration between scientists, physicians, and patients, we'll continue to make important discoveries every day, which will lead to better treatments for our patients and ultimately improve the lives for all patients with breast cancer. Thank you.
I walk for my wife.
All of my patients.
I walked so no other families have to go through what my family went through.
What if we all did a little bit more?
If we could raise one more dollar.
Take one more step.
Share one more story.
Imagine the impact we could make
towards ending breast cancer.
That's the power of one.
The power of one starts with you.
Every one of us.
Understanding the impact that we can
When
have.
we go $1,
one story,
a step further.
join us and witness the power of one.